Good evening, my friends. I'm going to limit myself to only the current modalities of treatment that are in vogue, and I'm not going to touch upon any future therapies. First of all, we must understand that alcoholic liver disease is the leading cause of cirrhosis globally. And not only that, it is also the leading cause of death because of cirrhosis globally. Similarly, severe alcohol-associated hepatitis is associated with a high mortality and morbidity. Alcoholic use disorder is associated with the high risk of relapse to high risk drinking behavior. And the pathogenic mechanistic complexity is also now known to vary with time of presentation of the hepatitis. In the early phase, we have hepatocellular necrosis, severe inflammation and bacterial translocation. In the late phase, we have decreased innate immune response and poor liver regeneration. So it's quite, we all know this slide that as we take alcohol, alcohol has got multiple effects. First of all, it will give rise to increased, because of small intestinal dysmotility, one has an increased number of gram-negative bacteria, and the number of good bacteria, that is the bacteroidetes and the lactobacilli, are less in number. Also, the gut permeability gets affected. Adding to that, then there is release of the PAMPs, that is basically the lipopolysaccharides or the endotoxins, which go through the portal vein and are basically attached to the TLR4 receptors in the macrophages. From there, further, there is release of several pro-inflammatory mediators such as alpha TNF, interleukin 1, interleukin 6, interleukin 8. Then there are many chemokines also that are in play. Finally, there is activation of neutrophil because of some of these chemokines and interleukin 8. And there is also hepatocyte stellate cell activation and formation of fibrosis and collagen and liver fibrosis. Coming to the drugs that have been used and are now currently gradually getting out of vogue, one is pentoxifylline. The two major studies, the STOPPER study and the DEFEAT alcoholic steatohepatitis study, have conclusively proved that this drug has now no role to play in the treatment of severe alcohol-associated hepatitis. Then came the turn of the inhibitors of interleukin 1. Anakinra is one drug that is antagonistically binding to the interleukin 1 receptor, and caniconab antagonistically binds to interleukin 1 directly. This is a slide that shows the mechanisms of both of them. Anakinra, in a combination along with pentoxifylline and zinc, was shown in the DEFEAT study, the DASH trial, and it showed the mortality rate that is similar in both the groups at 90 days, 70% for the combination and 60% for the steroid arm. This shows the Kaplan-Meier plot curve of the study. Then this year, the study came up from the Gavia group which showed that anakinra plus zinc, which compared the efficacy of this combination to prednisolone, and it has been published in Journal of Hepatology. It shows the survival rate is 90% in the prednisolone arm versus 70% in the anakinra arm. This survival rate is an outlier. This is a survival plot of the same study. But the question is, why is this an outlier? This study was started in the pre-COVID time, and in fact, it landed up. The protocol had to be amended during the COVID time because of lack of number of patients. Because the third arm, the GCSF arm, had to be excluded out. It was seen that younger patients presented with alcoholic hepatitis as a result of short duration of intense drinking, resulting in severe inflammation and then hepatocyte necrosis, which was steroid responsive, then a later stage of fibrosis. During this pandemic, it was noted that there was excessive drinking at home, reported globally. Most studies reported increased admissions because of alcoholic hepatitis or because of the related liver transplantations. Younger adults, 35-year-old to 44-year-old women, Hispanics, and Afro-Americans were at higher risk. These patients were more sicker at admission. 24% required HDU or ICU care. However, surprisingly, the mortality rates were found to be lower in most of these studies, probably because of the high response rates. Now, coming back to caniconab, this interleukin 1 binder antagonist was published as basically just as an abstract because of its negative results. Thus, we can conclusively say that there is a failure of inhibitors of interleukin 1 in this disease. This interleukin pathway is not an ideal target. There are divergent effects of interleukin 1 signaling in the renal tubular cells and in the endothelium. The redundancy in the inflammatory cytokine networks negate our therapeutic endeavors as far as these interleukin inhibitors are concerned. Then comes the turn of the granulocyte stimulating factors. There are several Indian studies, 3 Indian studies, 2 open-label studies from PGI, which showed an improvement in 3 and 6 months survival as compared to standard medical therapy, and a randomized double-blind trial that was published from ILBS, which showed that the steroid non-responders had an increased survival rate when they were given GCSF. On the other hand, in the West, most recently in 2022, a prospective open-label trial of severe alcohol-associated hepatitis, who were given prednisolone on one arm and pegfilgrastim along with steroids in the other arm, was done. A similar survival rate at 90 days was noted. The pegfilgrastim arm had a survival rate of around 69% versus prednisolone 83%. Previously, smaller European studies and a study in ACLF, mostly having alcohol-induced patients, using GCSF showed no improvement in survival versus prednisolone. And in an editorial, European editorial, it was stated that there was obviously no benefit in giving GCSF in their patients with severe alcohol-associated hepatitis. Thus, so far, we have no consensus on the role of GCSF in the treatment of severe alcohol-associated hepatitis. What about corticosteroids? Several recent prospective studies have found that it decreases the risk of death in these patients within 28 days. However, unfortunately, they only offer a short-term 1-month survival benefit, which disappears by 3 months. The mortality rate of these patients on corticosteroids at 90 days was 30% in the STOPPA trial, 30 days in the DASH trial, and 26% in the antibiotic trial, compared to the 10% in the outlier trial, that is the Gabriel trial. And I've already mentioned that was probably because of the lower mean age of patients, 44 years, that was seen in this particular last trial. The Cochrane systematic review that included 118 and 84 patients and 16 studies concluded that corticosteroids confer no clear benefit over placebo with respect to mortality at 3 months in patients with severe alcohol-associated hepatitis. And it also stated that as only one trial was at low risk of bias, it was more likely that the trials at high risk of bias are overestimating the benefits of the steroids and overlooking harm done by the steroids. In a large recent retrospective multi-center cohort study which involved thousands of patients, it was noted that the use of corticosteroids decreases the 30-day mortality by 41%, but however does not reduce mortality at 90 days or 100 days. They also showed that the maximum survival benefit of about 20 to 30% was seen in the MELD scores between 25 and 39. And there was a moderate benefit that was seen 10 to 20% with steroid therapy in those patients with MELD scores between 20 to 24 and 14 44. However, I must point out that this retrospective study's results are at odds with all the recent prospective studies which showed that steroids improve survival at 30 days in patients with MELDs ranging from 20 to 25, whereas this study showed a bigger benefit between 25 and 39. There are several contraindications which we are well aware to steroids, such as acute kidney injury, GI bleeds, pancreatitis, and active sepsis. Now, comparing the Indian studies, what is clear is that if you see the Western studies, the MDF ranges from somewhere between 54 to 69, that is around 55 to 70, whereas the MDF in Indian studies ranges from 70 to 85. The MELD score in the Western studies ranges from 20 to 25. In our studies, it ranges from 25 to 31. The mortality in the Western studies in the SMT arm that was shown in the STOPPA trial was 22% at 90 days, and in the steroid arm was shown at 30% in most of these trials. However, the mortality rate in our studies, most of our studies, has shown that it is close to 67 to 79% at 90 days. Thus, our mortality rate is much higher than those of the Western studies, probably because of the severity of disease in our patients. Few studies have clearly shown that the corticosteroid eligibility as a treatment option is very low, varying from 12% to 30%. And this is due to multiple reasons, contraindications, plus the fact that several of these patients have multi-organ failure, associated acute pancreatitis, and a very high MELD score or MDF score of more than 30 as per the NIA recommendations. Thus, the question is, are corticosteroids a treatment option in our patients? The inference is that our patients have much more severe disease with a much higher mortality rate. And as per the NIA, patients with a MELD score of more than 30 or a MADRS discriminant function of more than 60 have a very poor prognosis with a very high mortality rate. Hence, liver support approaches or urgent transplantation should be considered rather than pharmacotherapy. So the take-home message is corticosteroids a good treatment option in severe alcohol-associated hepatitis? All Western recent studies have concluded that corticosteroids decrease the short-term mortality, but not the medium or the long-term mortality. And in our country, obviously, they are in most cases not a therapeutic option for Indian patients with extremely severe alcoholic hepatitis. Hence, I believe that complex combination therapies are required for these patients because we have multiple mechanistic areas of pathogenesis which need to be regulated or controlled. We need to decrease inflammation, improve gut permeability, decrease bacterial translocation, improve immunity to prevent sepsis, and increase hepatocyte regeneration. I have not added a slide over here but because of time, I would suggest to most of my listeners is that we also need to understand that most of our patients are malnourished. Most of them have got severe sarcopenia, and if we do the simple hand grip strength, we'll find that they are severely this got sarcopenia. And we well know that sarcopenia has a direct impact on the immune system. That leads to a fact that most of our patients are not suitable for corticosteroids. Therefore, we need to think out of the box to have better solutions to our patients. And even in the West, they need better treatments because of the no correlation between steroids and the medium or the long-term mortality. Thank you.